an accessory pathway connecting the ventricles, the initial portion of this conduction will be delayed here because this accessory pathway is going to depolarize the ventricles early. So here you have a delta wave because this accessory pathway is going to depolarize the ventricle and this impulse is going to go through slowly. So you will have a normal PR with a delta wave. We can think it may be a Maheim fiber pre-excitation. So let us look at the ECGs. We have looked at the concept. Atrioventricular is Ken bundle, short PR with a delta wave and QRS. Atriohisian bundle is James pathway, which is short PR with a normal QRS. And Maheim fiber is nodoventricular or vesiculoventricular, normal PR with a delta wave. So now you look at the Ken bundle where the AV node is bypassed and subsequent conduction is slow. So because the AV node is bypassed, you have a short PR interval. And because this initial depolarization is going through the muscle, this will result in initial delay of the QRS, which produces what is known as a slur in the QRS, which is called the delta wave. So the initial delay, the QRS gets widened. The QRS is widened because of the initial depolarization is going through the muscle. So ultimately what happens is the impulse coming through the normal conduction system fuses with this impulse to produce the terminal portion of the QRS complex, which is very short. So short PR delta wave is due to Ken bundle, which can initiate a WPW syndrome or a WPW pattern. Then of course whenever you have a James pathway which is going to bypass the AV node and going to conduct your regular conduction system, here the AV node is alone bypassed, but subsequently the impulse is not going through the muscle. So there is no question of QRS widening or initial delta wave. What you will have is a short PR interval, but there is no delta wave and the QRS is narrow. So short PR with no delta wave or normal QRS is probably due to James pathway. When this ECG, when the patient with this ECG, when he has recurrent episodes of tachycardia only, is called as having Lowen-Ganong-Levin syndrome, LGL syndrome. So short PR, no delta is the James pathway conduction and the tachycardia is LGL syndrome. Then Maheim fiber is the one which is not going to bypass the AV node, but subsequently the impulse is going to go through the accessory pathway to pre-excite the ventricle through the muscle. So what will happen is you may have a normal PR interval, but your initial portion of the QRS may be slurred. As you can see it nicely here, the PR interval is normal and the initial portion of the QRS is slurred, which will tell us that the AV node is bypassed, but nevertheless, the initial portion of the QRS is happening through the muscle because of the pre-excitation by the Maheim fiber. So this can be due to Maheim fiber conduction. So from the ECG itself, looking at the PR interval, the QRS width as well as the delta wave, we can identify whether the pre-excitation pathway is Kent, James or Maheim. So these are the types of pre-excitation. Then we will concentrate the commonest pre-excitation syndrome, which is a WPW syndrome and WPW pattern. So you are going to learn about Wolff-Parkinson-White syndrome and pattern. So Wolff-Parkinson-White syndrome is described in 1930 by three important scientists. One is the Louis Wolff, John Parkinson and Paul Dudley White. So these three people describe this syndrome as the cause of episodes of tachyarrhythmias, episodes of tachycardia. The incidence is anywhere between 0.1 to 3 per 1,000 patients, 1,000 people, and the most important practical implication of knowing about WPW syndrome is not only for the episodes of tachycardia and the treatment of tachycardia, some people may have a risk of sudden cardiac death, especially it may run in families. So what is causing this Ken bundle pre-excitation or WPW syndrome or pattern? So as I told you, we have the normal conduction system of the heart, which has got the AV node, the SA node, AV node, his and the bundle branches, vesicles and Purkinje fibers. You have an accessory pathway here, which is connecting the atrium to the ventricle. The location of the accessory pathway may be anywhere. Most often it can be on the right side or it can be on the left side. So it can be in the anteroseptal region or in the posteroseptal region. It may be in the right free wall or in the left lateral wall. So anywhere in the heart, this accessory pathway can be located. But the most important thing is it is going to conduct the impulse from the atrium to the ventricle bypassing this AV node. So let us first understand what is the normal QRS complex in sinus rhythm when there is an accessory pathway of gate. So what happens is when the sinus node produces the impulse is going to go through the normal conduction system as well as through the accessory pathway. So impulse through the accessory pathway will quickly reach the ventricle because there is no delay here. So having reached the ventricle quickly, because of reaching the ventricle quickly, your PR interval is short. Having reached the ventricle, then subsequently this impulse is going through the muscle and it is getting slowed down. So that's why there is here the muscle is conducting at 0.5 meters per second. So the initial portion of the ventricular depolarization is terribly slowed because the impulse is conducted slowly through the muscle. That will result in the initial slur of the QRS complex, which is called the delta wave. As this impulse is spreading, after the AV nodal delay, the impulse will be rapidly conducted through the specialized conduction system of the heart and depolarize the ventricles as this impulse is slowly spreading. So the terminal portion of the QRS complex will be contributed by the impulse portion which is coming through the normal conduction pathway. That will result in the initial sharp portion of the QRS complex, which constitute the impulse portion which is coming through the normal conduction pathway. So your QRS complex, PQRS complex in the end pathway pre-excitation is the fusion of the impulse fronts which is coming through the accessory pathway as well as through the normal conduction system. So that's why it is a fusion complex of the impulse front coming through the accessory pathway which causes the delta wave and the impulse front coming through the normal conduction system in the form of terminal sharp QRS complex. So this is how we understand the QRS configuration in patient in sinus rhythm when they have a Kent bundle accessory pathway or Kent bundle pre-excitation. So basically you can see that here now in this animation that the impulse which is produced by the sinus node is first going through the accessory pathway and slowly depolarizing the ventricle before the impulse front which is coming through the normal pathway is also late. Then it is traveled very fast and depolarize the rest of the ventricles. So the portion of the QRS which is coming through in this red portion which is actually reach the ventricle quickly, and the red portion is a slow depolarization of the ventricles. So that causes because the AV node is bypassed, you have a short PR interval, and the impulse portion which is coming through the accessory pathway and spreading through the muscle is causing the delta wave. Then of course the terminal portion is contributed by this impulse is slowly spreading. The impulse after the AV node delay rapidly gets conducted to the conduction system of the heart and then produce the terminal portion of the QRS complex which is very sharp. So this is the fusion complex of the QRS complex in the Kent bundle pre-excitation, short PR, delta, and of course the terminal portion of the QRS complex which is coming from the normal conduction system of the heart. So understand this Kent bundle pre-excitation, you can see this animation. The impulse through the accessory pathway is rapidly reaching the ventricle as this man is running fast and rapidly reaching the ventricle. After reaching the ventricle, he slows down and stops, and before that, and not stopping, actually it slows down, and by the time the impulse coming through the normal conduction system take over to produce the terminal portion of the QRS complex. So that's why you have the initial delta and the terminal portion of the QRS complex in QRS of a Kent bundle pre-excitation. So from the ECG, so now we know that one portion of the QRS is contributed by the impulse front coming through the accessory pathway, and one portion of the QRS is contributed by the impulse front coming through the normal conduction system. By looking at the ECG itself, it is possible to say which pathway, whether the accessory pathway is conducting more or the normal conduction system is conducting more. So whenever you have a very short PR interval, as you can see that here, that P wave is sitting on the QRS and you have a very large delta wave resulting in a significant QRS prolongation. You can see 140 milliseconds is the QRS prolongation. So when you have a very sharp and a large delta wave with a very wide QRS complex because of the initial delay, you know the impulse front coming through the accessory pathway is much more than the impulse front coming through the normal conduction system. So whenever you have a short PR, large delta with a very wide QRS, you know the impulse front through through the conduction, the autonomous pathway is more than the impulse front coming through the normal conduction system. Whereas, whenever the impulse front through the normal conduction system is more than the impulse front which is coming through the accessory pathway, you have almost a lower limit of the PR interval. Just PR interval is just short, and you see a very small delta wave, and the QRS is not very wide. You have a very small delta wave telling you that the accessory pathway impulse conduction is small, and the impulse conduction through the normal conduction system is small. So whenever you have a borderline short PR and a small delta wave, it means the conduction front through the normal conduction system is more than the conduction through the accessory pathway. Whenever you have a very short PR and a large delta wave, it tells you the accessory pathway conduction front is more than the normal conduction system. So in this way, from the ECG itself, we know when two pathways are conducting, which pathway is conducting more and which pathway is conducting less. So the very important differential diagnosis for a white QRS is the bundle branch block. Of course, the bundle branch block is the commonest cause of white QRS, which we saw in one of our lectures in this series. So because compared to the white QRS due to pre-excitation, white QRS due to bundle branch block is much more common. What is the difference? We have already discussed this. Whenever there is a white QRS and the width of the QRS is widened, because of the initial delay in the QRS, it is likely to be Kent bundle pre-excitation. Because in Kent bundle pre-excitation, the initial portion of the ventricular depolarization is going through the muscle. That's why it is getting delayed in the initial part. Whereas I told you about the bundle branch block. Bundle branch block, what we have to see is the terminal delayed slurred positivity over the right sided lead in right bundle branch block, delayed slurred positivity over the left sided lead in left bundle branch block. In bundle branch block happens, the initial conduction is going to go through the normal conduction system to the intact ventricle and then travel from the intact ventricle to the ventricle which the bundle is blocked through the muscle. So in a bundle branch block, the later portion of the ventricular depolarization is delayed, or the later portion of the ventricular depolarization is going through the muscle. That's why there's a terminal delay in bundle branch block, whereas the initial delay in the Kent bundle pre-excitation, and the commonest cause will be the bundle branch block, but the Kent bundle also can produce the pre-excitation white QRS. So what is the difference between a WPW pattern and WPW syndrome? For example, you take a ECG for a routine ECG for a completely asymptomatic person who did not have any episodes of tachycardia, and the ECG shows a short PR and a delta wave, and the patient does not have any episodes of tachycardia or palpitation. It is a routine detection of this particular QRS complex in your ECG. It is called WPW pattern in the electrocardiogram. Whereas the patient has got recurrent episodes of palpitation, or he already has a recurrent episodes of documented tachycardia, then he is called as the Wolff-Parkinson-White syndrome. So that is the difference between Wolff-Parkinson-White pattern and Wolff-Parkinson-White syndrome. So we can easily summarize our understanding of the Kent pathway pre-excitation, the WPW syndrome and pattern by this cartoon. So it is because of an accessory pathway which is connecting the ventricles, atria to the ventricles. Because the AV node is bypassed here, you have the short PR interval. Once the impulse reaches the ventricle, it goes through the muscle, which delays the impulse conduction in the initial portion of the QRS complex, causing the initial delay, which is called a delta wave. And subsequently, the terminal portion is caused by the impulse front coming through the normal conduction system, and because of this initial delay, it results in the white QRS complex. And this initial delay is because of the pre-excitation of the ventricles by the accessory pathway. So when this patient has got intermittent tachycardia or a documented episode, is called as Wolff-Parkinson-White syndrome, but only we have an ECG pattern which is accidentally detected. In an asymptomatic person, it is called Wolff-Parkinson-White pattern in the ECG. Having understood the Wolff-Parkinson-White syndrome and pattern, and what arrhythmias are going to be produced by this particular Kent bundle, and how arrhythmias are produced. So what are the arrhythmias? How these arrhythmias are produced? The most difficult part in this lecture. So the arrhythmias produced by the Kent bundle or the WPW syndrome is going to be one narrow QRS regular tachycardia, which is happening because of the re-entry mechanism between the atrium and the ventricle involving the accessory pathway. It is called atrioventricular re-entry tachycardia, atrioventricular reciprocating tachycardia, which is called AVRT. We call them as orthodromic tachycardia. So whenever there is a narrow QRS tachycardia due to WPW pattern or a Kent bundle, we call them as orthodromic tachycardia, by which we mean antegrade conduction is through the normal conduction pathway and retrograde conduction is through the accessory pathway. We'll explain that in subsequent diagrams. Then you can have two types of white QRS complex tachycardia due to accessory pathway of Kent, which can be a white QRS regular tachycardia, where your supraventral tachycardia, like the atrial tachycardia, most often atrial flutter, is conducting antegradely through the accessory pathway and go through back to retrogradely through the normal conduction system, or it is getting conducted through the accessory pathway to the ventricle. So when it goes through the accessory pathway, because accessory pathway is conducting the muscle and subsequent impulse is going to go through the muscle, there will be white QRS. If your supraventricular arrhythmia is a regular arrhythmia such as atrial flutter or tachycardia, you will have white QRS regular tachycardia, which we call them as antidromic tachycardia, because antegrade conduction is through the accessory pathway. That's why we call them as antidromic tachycardia. The most dangerous type of tachycardia you can have in the WPW syndrome is white QRS irregular tachycardia, where your supraventral tachycardia is irregular and fast, which is atrial fibrillation. So when the patient has got atrial fibrillation, majority of impulses will be going through the accessory pathway, which does not have the protection of the AV node, which is going to block certain impulses and allow certain impulses to the ventricles. So this will result in many of these atrial fibrillation impulses rapidly getting connected to the ventricles. So this results in a very rapid ventricular response or the ventricular rate due to atrial fibrillation of antidromic parenty. That means atrial fibrillation impulses are antegradely conducted through the accessory pathway and results in antidromic atrial fibrillation. The most dangerous and life-threatening arrhythmia which can cause sudden death is antidromic AF in WPW syndrome. Let us understand what we mean by orthodromic tachycardia and antidromic tachycardia. I already told you how to understand the normal sinus rhythm QRS complex in WPW syndrome. So the WPW syndrome, the impulse from a single sinus node impulse is getting conducted through the accessory pathway first to reach the ventricle, and then it slowly depresses ventricular muscle, which results in short PR and initial delta before the normal conduction system impulse front, which is coming out of the gray, is going to rapidly spread and produce the terminal portion of QRS complex. So here, in a normal sinus rhythm, both pathways are going to conduct simultaneously. Both pathways are conducting, not simultaneously, both pathways are going to conduct the impulse to the ventricles. Atrial accessory pathway is little early and the conduction system is little late because of the AV node conduction. But what happens in a re-entry tachycardia is a re-entry circuit is established because of a premature beat which is blocking one of these pathways. So in an orthodromic tachycardia, what happens is you have a re-entry circuit here. The re-entry circuit, the antegrade conduction will happen through the normal conduction system and the retrograde conduction will be happening through the accessory pathway. So this is called antidromic tachycardia. The re-entry circuit will involve antegrade conduction through the normal pathway and retrograde conduction through the accessory pathway. Because the normal conduction is going through the normal conduction, antegrade conduction going through the normal conduction system, your ventricles are going to be activated by the specialized conduction system of the heart. That's why this tachycardia will have a narrow QRS tachycardia. So this QRS tachycardia, so the narrow QRS regular tachycardia will be having orthodromic tachycardia due to WPW syndrome or the Kent bundle, where the antegrade conduction is through the normal pathway, retrograde conduction is through the accessory pathway. Whereas in antidromic tachycardia, the re-entry circuit is opposite. Here, the antegrade conduction is going through the accessory pathway and retrograde conduction is through the normal pathway. Because the antegrade conduction is going through the accessory pathway, because this accessory pathway is going to connect to the muscle, and then the impulse is going to the muscle. The QRS tachycardia, the QRS of the tachycardia is going to be wide. So this is called antidromic. The antegrade conduction is through the accessory pathway. Depending upon whether your supraventricular arrhythmia is regular like atrial flutter or irregular like atrial fibrillation, this wide QRS complex tachycardia can be regular or irregular antidromic tachycardia. So this is the understanding of the tachycardias in 2 to 10 bundle re-excitation, 10 bundle pre-excitation and re-entry arrhythmias. First, we look at the orthodromic narrow QRS complex tachycardia. Here what happens is, when the re-entry circuit is established, the antegrade conduction is going to go through the normal pathway. That's why it's a normal pathway will depolarize the ventricle, which results in narrow QRS complex. And the retrograde conduction is going to go through the associated pathway, which results in narrow QRS tachycardia, RSVT. So, in this re-entry circuit will involve the antegrade conduction through the normal pathway and the retrograde conduction through the accessory pathway, which results in narrow QRS complex regular tachycardia, which is one of the commonest supraventricular tachycardia. So as you can see it here, the normal conduction is through the normal pathway. When the re-entry circuit is established, as you can see, the retrograde conduction is going to go through the accessory pathway. As you can see, the re-entry circuit, when it comes, it is going to go through the accessory pathway, and the antegrade conduction is going to come through the normal pathway. So this results in the re-entry circuit of the narrow QRS variety of a tachycardia. So the important thing to understand how to recognize during the tachycardia itself that this tachycardia is due to orthodromic tachycardia of the WPW syndrome. So when you have a previous ECG or after converting the ECG, if you are diagnosing the WPW syndrome, many people will diagnose. But if you don't have any ECG before, during the tachycardia itself, how to know that this tachycardia has got basic 10 bundle pre-excitation. For that you have to understand, when there is a tachycardia happens, the antegrade tachycardia happens. So the antegrade conduction is through the normal pathway and the retrograde conduction is through the accessory pathway. Here you can understand and carefully see your antegrade conduction of the ventricular depolarization is occurring early and your retrograde conduction of the atrial depolarization is occurring late. Because the retrograde P wave has to reach the accessory pathway and then depolarize the atrium. What we mean by retrograde atrial activation is, the atrial activation is going to go from inferior to superior, which results in inverted P waves in L2, L3 AVF. So first the QRS will happen because of the antegrade conduction through the normal pathway. Then the retrograde atrial activation happens after the initiation or after the recording of the QRS complex of the normal conduction pathway. So here in atrioventricular re-entry or atrioventricular respiratory tachycardia, utilizing accessory pathway, your atrial retrograde atrial depolarization is little delayed than the antegrade ventricular activation. So as you can see it nicely here, that antegrade activation is coming and it takes some time for this impulse to reach the accessory pathway to retrogradely depolarize the atrium. So that's why the retrograde P wave, which is recognized as inverted P wave in L2, L3 AVF, is going to be inscribed after the QRS complex in the ST segment, because the retrograde activation is little later than the antegrade activation through the normal conduction system. So what you have to see in a narrow QRS complex regular tachycardia is whether I have a retrograde P wave which is recognized inferior leads after the QRS. When it is there, you can suspect the Ken bundle pre-excitation, or it can be a pre-excited tachycardia, or it is atrioventricular respiratory tachycardia, rather than other type of tachycardia such as AV nodal re-entry tachycardia. You can look at this ECG here. The patient has got a narrow QRS complex regular tachycardia. So once I have a narrow QRS complex tachycardia, what I have to see is whether I have an inverted P wave like this in the inferior leads after the QRS inscription. So as you can see it now, the QRS has come, my ST segment is deformed by the inverted P waves or negative P waves in the ST segment. So whenever this inverted P wave is little beyond the QRS, I understand the antegrade ventricular activation is acting early and retrograde atrial activation is coming little late, because it has to go through retrogradely, reaching the accessory pathway then only to the atrium. So whenever this type of retrograde P waves happen little after the QRS, a little bit delay from the QRS, during the tachycardia itself I know this tachycardia is due to basic WPW syndrome. So just to impress people, during the tachycardia itself we can say, when you take this patient revert and you take this patient is normal ECG, you will have a WPW syndrome pattern and people will be astonished by your ECG knowledge. So just keep looking for this inverted P wave in the ST segment. Whereas the next most important commonest narrow QRS complex tachycardia is AV nodal re-entry tachycardia. Here the re-entry mechanism involves the AV node only. So here the most common type of AV and RT is slow. The AV node is divided in two parts in the people who are prone for it. So there will be a slow pathway and there will be a fast pathway in the AV node itself, which initiates the tachycardia, the re-entry tachycardia. So what happens is the antegrade conduction will be going through the slow portion of the AV node, and retrograde conduction will be happening to the fast portion of the AV node. So retrograde conduction is fast, antegrade conduction is little slow. So what happens is, because of the retrograde conduction to the atrium is very quick, your QRS as well as the P wave will be inscribed simultaneously, because our retrograde conduction is fast through the retrograde fast pathway of the AV node. So here you will have a narrow QRS complex tachycardia, all right, but you will never have the inverted P wave deforming the ST segment after the QRS. So whenever you have only the QRS complex with no P wave in front, no P wave at the back, then the diagnosis will be atrioventricular reciprocating tachycardia, atrioventricular nodal reciprocating tachycardia. Look at the tachycardia here. It is the tachycardia first, narrow QRS tachycardia next, and then the regular tachycardia. Carefully see the ST segment inferior leads. There is no distortion of the ST segment in this ECG. So here what you know, there is no P wave in front, there is no P wave at the back. So what you understand from this electrocardiogram is, in this ECG, my antegrade conduction to the ventricle and retrograde conduction to the atrium are occurring simultaneously. That means my retrograde conduction is happening fast through the fast pathway of the AV node. So in this ECG I can say boldly, the mechanism of re-entry is within the AV node, and this is the AV nodal re-entry tachycardia. So just compare this ECG here. We can beautifully see that retrograde P wave, the ST segment, and you see the ST segment inferior leads. So this is why we diagnose the orthodromic tachycardia versus the AV and RT. So what are the differences between AV and RT and atrioventricular reciprocating tachycardia involving the TED bundle? So AV and RT is most often in elderly, AV-RT is most often in the young. The women predominate in AV and RT. Both sexes can have AV-RT. So the AV and RT, because of the simultaneous activation of the ventricles and the atrium, because the QRS and the P waves are acting simultaneously, for all these beats, your right atrium is going to contract against the closed tricuspid valve because of the ventricular contraction. So whenever the right atrium is going to contract against the closed tricuspid valve, you will have a Cannon wave. Because of all the right atrial pressure will be transmitted to the jugular veins. So for all these beats, right atrium is going to contract against the closed tricuspid valve. So you'll have what is known as the regularly occurring Cannon wave, which is called the frog sign. You imagine the throat of the frog which is pulsating regularly. So whenever during the narrow QRS complex tachycardia, even we are not very sure about the retrograde P wave in inferior leads, look at the JVP. So in a narrow QRS complex tachycardia, if you have a regularly occurring Cannon waves or a frog sign, it is likely to be AV and RT. This may not happen in a pre-excited tachycardia or orthodromic variety, because my atrial activation is little later than my ventricular activation. So this may not happen here. So that's why the AV-RT patients, the most important history is the family history and syncope in the patient. And of course, the PR, the retrograde P wave is very short and may be happening inside or just after the QRS in AV and RT. It will be happening little late in patients with AV-RT. Sometimes you may have a QRS alternance, but this is not a very good sign at present in AV-RT. But when you take the ECG after the conversion sinus rhythm, most of the time the AVRT may show a basic WPW syndrome pattern. So this is how we understood orthodromic tachycardia, and the differential diagnosis of orthodromic tachycardia is the AV and RT. I told you how to recognize. Then we come to antidromic tachycardia, which are more dangerous and more important. Here, the re-entry circuit is going to involve antegrade conduction through the accessory pathway and the retrograde conduction through the normal pathway. Because the antegrade conduction is going to be the normal pathway, two things are happening. One, the antegrade conduction or accessory pathway is going to conduct the impulse through the muscle, so you are going to have a white QRS complex tachycardia. Second, there is no protection of the AV nodal delay or the block or the AV nodal protection to the ventricle from a sparse supraventricular arrhythmia is not there for accessory pathway. Means all of your supraventricular tachycardic impulse will be conducted through the accessory pathway to the ventricle. That means you are going to have a very fast tachycardia. So white QRS complex tachycardia, very fast tachycardia, because the AV nodal protection, what the main function of the AV node is to protect the ventricle from a very fast supraventricular impulse, so that whenever there is atrial fibrillation or atrial flutter, what the AV node will do is stop some of the impulses, some of the atrial impulses, or block some of the impulses and conduct some of the impulses to the ventricle, so that it makes sure that the ventricular response is kept under control. So this protection may not be happening through the accessory pathway. So this results in two things: white QRS complex tachycardia and a very fast tachycardia. And that's why it is very, very dangerous to have orthodromic tachycardia. Depends upon whether my supraventricular tachycardia is regular or irregular. I can have a white QRS complex regular tachycardia. I have a white QRS complex irregular tachycardia. Look at here now. Whenever my re-entry circuit is through the accessory pathway, I will have a white QRS complex tachycardia. Whenever my retrograde conduction is through the accessory pathway, I will have a narrow QRS complex tachycardia. So antidromic tachycardia is whenever my antegrade conduction is through accessory pathway and retrograde conduction is through the normal pathway. So that is called antidromic tachycardia. Antidromic tachycardia will result in what is known as white QRS complex tachycardia, because my antegrade conduction is through the accessory pathway, which is actually getting conducted, the impulse is getting conducted through the muscle. So look at the CCG here. Superficially, it will look like a ventricular tachycardia because it is a white QRS complex regular tachycardia. So it's a white QRS complex regular tachycardia, and you always have a temptation to diagnose a ventricular tachycardia. But look at the rate. The rate is almost 300 per minute, one big square here. So no ventricular tachycardia can have a rate of 300 or 310 per minute, because any ventricular tachycardia more than 200 or so may degenerate to ventricular flutter or fibrillation. So whenever you have a white QRS tachycardia with a very, very fast heart rate like this, it automatically means you have an atrial flutter in the superior region. The flutter is going around 300 per minute. All the 300 impulses are going through the accessory pathway to reach the ventricles. So all your atrial flutter impulses are getting conducted through the accessory pathway, so that your ventricular rate becomes 300 per minute. So that is a very important clue whenever you have a white QRS complex tachycardia. Usually the white QRS complex tachycardia of ventricular variety or a supraventricular tachycardia with an aberrancy may not have this rate. Only the accessory pathway or pre-excited tachycardia will have this rate. As you can see, you can also see some of the initial delay in the QRS complexes telling you that the impulse is coming through the accessory pathway to the muscle. You can see that initial slur there. So most of the ventricular tachycardias will have the terminal delay in the QRS, whereas the accessory pathway mediated tachycardias will have delay in the initial portion of the tachycardia. So that is another important difference when you look at that initial delay versus the terminal delay. So if you have the initial delay in the white QRS complex tachycardia and the rate is very fast and it is regular, you can always suspect an atrial flutter conducted through the accessory pathway. So it is antidromic regular white QRS complex tachycardia. Now look at white QRS complex irregular tachycardia. This is atrial fibrillation. Whenever there is atrial fibrillation, the heart rate is going around the 400 to 500 per minute. All this now, some of the impulses are getting delayed and connected to the AV node, and many of the impulses are going to come through the accessory pathway, because the accessory pathway is not going to have any delay. So the atrial fibrillation impulses are very happy to go through the ventricles very quickly through the accessory pathway through the express train rather than the passenger train. So many of your fibrillar impulses will be reaching the ventricle very fast. So in atrial fibrillation, because the AV node is not able to conduct and block all the impulses, so your ventricular impulses are going to come through. You can see the red impulses which are coming through the accessory pathway, coming very fast. So you'll have a very fast heart rate, but irregular heart rate, because basically your supraventricular tachycardia is irregular. So these irregular impulses are coming rapidly through the accessory pathway. So whenever you have a very rapid irregular tachycardia, very rapid irregular white QRS complex tachycardia, you must suspect antidromic atrial fibrillation, the most dangerous arrhythmia of WPW syndrome. Look at this ECG here. I have a white QRS complex tachycardia, all right, but I have irregular narrow QRS complex tachycardia. Look at the QRS with duration here, RR interval here. Look at the RR interval, constantly changing. And see the rate in some of the times, some of the ECG, some of the segments of the electrocardiogram. You can see in this segment, I have rate of almost 300 per minute. So a normal intact AV node will not conduct 300 impulses to the ventricles at all. So when you have an atrial fibrillation, irregular tachycardia, white QRS tachycardia, when your rate is more than 200 or 250 per minute, and not only that, very fast irregular rate, but the QRS complexes are constantly changing. You can see the QRS complexes is wide here, little narrow here, little bit medium here. So constantly changing the QRS complexes in the configuration. Why this is happening? Because some of the impulses are getting conducted through the AV node, combined through the AV node and accessory pathway. Some of the impulses are coming through the accessory pathway only. So this resulted constant changing of the QRS configuration in a particular given lead. So very fast irregular heart rate with a changing QRS configuration, you must suspect this is antidromic atrial fibrillation, which means atrial fibrillation, antegrade conduction is happening through the accessory pathway, and this is results in very rapid irregular heart rate. So this is antidromic AF. It's a very, very dangerous arrhythmia in WPW syndrome. I'm just going to show you what will happen in a regular atrial fibrillation with a pre-existing bundle branch block, which can also produce irregular white QRS complex tachycardia. So once again, you can say this is an atrial fibrillation. You don't have the accessory pathway here. All your atrial fibrillation impulses are going to conduct through the AV node only. So what the AV node does, it makes sure your heart rate is not going beyond 170 or 180 maximum. So that it protects the ventricle from a rapid supraventricular by blocking certain fibrillary impulses and then allowing only certain impulses to the ventricle. So you have a white QRS complex irregular tachycardia, all right. Because here the atrial fibrillation has happened in a patient who already had a left bundle branch block. As you can see, the white QRS is because of the left bundle branch block, tall terminal positivity in B5, B6 and negativity in B1. And in a given single lead in B6, you see the QRS complexes are exactly looking same. There is no significant change in the QRS configuration and my rate is less than 200 per minute. Then I can suspect this atrial fibrillation is going through the AV node only, and it is why the QRS is wide, because this patient would have had either a pre-existing bundle branch block or the bundle branch block would have come because of the tachycardia dependent bundle branch block. So it is not due to pre-existing. So just look at the B6 alone in this patient. See the rate, it's almost 300 and change in the width of the QRS. And look at this B6, the QRS rate is slow and the QRS configuration is same. This is how we differentiate between atrial fibrillation of antidromic variety versus atrial fibrillation due to a classical bundle branch block where all impulses are coming to the normal conduction system. So now we have understood clearly what is orthodromic tachycardia, which can result in narrow QRS complex tachycardia. Why antidromic tachycardias are happening? What are the two types of antidromic tachycardia, which can be regular or irregular? So now we come to the management, which can be acute management versus a long-term management. So many times when the patient has got orthodromic narrow QRS complex tachycardia, we can use the drugs like adenosine, verapamil or amiodarone. But the most important clinical point is, whenever in the previous slides when I talked about differentiating between AVNRT and AVRT, you may wonder the both are tachycardias and both I am going to give adenosine. Why should I differentiate whether the narrow QRS complex tachycardia is due to AVNRT or due to Ken bundle? Very important practical point is whenever you use adenosine, it is going to act on adenosine or diltiazem or verapamil. They are going to act on AV node only. But when you use amiodarone, it is going to act on accessory pathway as well as the AV node. Sometimes what happens is this SVT may not respond to your adenosine, and that means it may be utilizing the accessory pathway as the re-entry mechanism of retrograde conduction. There, the amiodarone only will revert the supraventral tachycardia into sinus rhythm because amiodarone will act on accessory pathway and as well as in the AV node, whereas the other AV nodal drugs will be acting on the AV node only. That is a practical implication. But the most important thing is do no harm. So whenever you have a white QRS complex tachycardia with a very fast heart rate or a very fast heart rate which is regular or irregular, and you have a doubt that it can be an antidromic tachycardia, don't ever use verapamil, digoxin and adenosine. So this is a very important advice because please remember, in antidromic tachycardia, my accessory pathway is conducting the impulse, and especially in atrial fibrillation, some of the impulses are also going through the AV node, and the AV node is trying its best to block some of the impulses to the ventricles. So when you give verapamil, digoxin, adenosine in this patient who has got a atrial fibrillation, what these drugs will do is completely block the AV node and allow all your atrial fibrillation impulses to go through the accessory pathway, resulting in a very rapid ventricular rate and ventricular fibrillation and sudden death. So that's why these drugs should not be given whenever you are suspecting a white QRS complex tachycardia, which can be a ventricular tachycardia, which can be antidromic regular tachycardia or antidromic irregular tachycardia. Amiodarone, which will be a preferable drug because the amiodarone is going to act on accessory pathway as well as the normal conduction system, and it is also a good drug for a white QRS complex tachycardia due to ventricular tachycardia. So, but one exception I want to tell you about antidromic tachycardia is most of our teaching, we will say that whenever the arrhythmia is hemodynamically stable in the presence of a normal heart rate, normal blood pressure, you try to give a pharmacological treatment and then give electrical treatment. And whenever the patient is hemodynamically unstable, you straight away give the electrical treatment. But the exception is in antidromic tachycardia. In antidromic tachycardia, whether it is regular white QRS or irregular tachycardia, this patient can deteriorate any time to a very fast heart rate and BF. So that's why even though the patient is hemodynamically stable, in antidromic white QRS complex tachycardia, be regular tachycardia or irregular tachycardia, always use an electrical therapy to convert them into sinus rhythm. So this is a long-term management of a patient with atrioventricular respiratory tachycardia. It all depends upon whether you have a pre-excitation configuration in the ECG or not. So if the patient is willing with a pre-excitation and is explained a possibility of future tachycardia, if he is willing for ablation, the patient don't go for ablation. Otherwise, a long-term management will be having a flecainide and propofenone if the patient has got no structural heart disease, beta blockers and amiodarone when the patient has got a structural heart disease. So similarly, when the patient has got concealed accessory pathway, which I will describe later, it can be willing for ablation, can go for ablation. Otherwise, the same approach of beta blockers in patients who are not going ablation, or amiodarone when there is a structural heart disease, flecainide and propofenone when there is no structural heart disease. What are the indications to do radiofrequency ablation in WPW syndrome? Even one episode of either orthodromic or antidromic tachycardia in WPW syndrome is an indication to do a radiofrequency ablation. Even once episode is enough as the indication for ablation. If the patient has got even one episode of atrial fibrillation, a pre-excited atrial fibrillation, white QRS fast irregular tachycardia, it is an indication to do RF ablation. When you have an atrial fibrillation and pre-excited RR interval in your atrial fibrillation is less than 250 milliseconds, immediate radiofrequency ablation. I tell you something about how to deal with a WPW pattern in a patient who does not have any symptoms. So the another indication to do radiofrequency ablation is a patient with the WPW syndrome with a very strong family history of sudden death. So these are the indications to do radiofrequency ablation in pre-excitation syndrome. So now we come to the most important part. So this is the patient who, for him, you routinely took an ECG, and this patient did not have palpitation, did not have syncope, family history of sudden death or structural heart disease, and you have found there is a short PR and the initial delay in the QRS complex. That you went into the history again and again. There is no history of tachycardia or a documented epicardia. How will you approach a patient who has got asymptomatic WPW pattern in the ECG? So the risk stratification is the key. So although the patient is asymptomatic, the most important history is a family history, and in this patient, whether the patient has got even one episode of pre-syncope or syncope, and what pathway you are dealing with. And sometimes a treadmill test in this patient may give you a clue whether you have a dangerous accessory pathway or little less dangerous or a benign accessory pathway. So we have done the stress test to this patient who is completely asymptomatic. So when the heart rate is 70, as you can see, the patient is classically manifesting short PR and a delta wave. That means at the heart rate of 70, the impulse is being conducted through the accessory pathway as well as through the normal conduction pathway. When I start an exercise test, when the heart rate goes to 180, you can find there is a complete disappearance of the delta wave and also the short PR interval. What does it mean? When the tachycardia happens, your accessory pathway is not conducting the impulse. Only your AV node is conducting the impulse. It automatically means your accessory pathway has got a long refractive period. So only when the heart rate is slow, it is able to conduct. Whenever you start the tachycardia or when you start the treadmill test, when the tachycardia happens, because of a long refractive period, the impulse is getting conducted through the normal pathway only and not through the conduction system, not through the accessory pathway. So whenever you have a long refractive period of the accessory pathway, it is likely to be less dangerous, because even though you have a fast ventricular response like your atrial fibrillation, here we have demonstrated during the tachycardia, accessory pathway is getting blocked. Similarly, when you have a fast ventricular supraventricular arrhythmias, your accessory pathway may not conduct the impulses to the ventricles. So that is an important scientific clue to say, whenever during the tachycardia, initiation of the tachycardia itself, if I have the disappearance of the delta wave and short PR, I have a long refractive period of the accessory pathway. That means during AF or flutter, this accessory pathway is unlikely to conduct antigravely. So that's why whenever you have a treadmill test, if as soon as the heart rate increases, if your delta wave disappears and the short PR disappears, it is little bit benign type of accessory pathway, which means your accessory pathway has got a long refractive period and it is unlikely to conduct antigravely through whenever you have a faster supraventricular arrhythmia. In contrast to that, the delta wave and the PR interval is persisting throughout the tachycardia, or when you have a normal ECG and during the tachycardia, the PR interval is start and getting shorter and the delta wave is appearing, it tells you that accessory pathway refractive period is very, very short. So, which tells us that when during the tachyarrhythmia, such as AF and tachyarrhythmias, this accessory pathway is going to conduct antigravely to the ventricles, resulting in a fast ventricular response. And this is a very dangerous accessory pathway which has to be radiofrequency ablated. So, how can I predict an asymptomatic WPW patient is going to have a sudden cardiac death? For that, we can do some EP studies, and if at all this patient is going to have an EP studies, you will initiate a tachycardia or an atrial fibrillation, and the RR interval in atrial fibrillation is very short. That means that this accessory pathway has got a very short refractive period, and it is a very dangerous accessory pathway and need for an ablation. Multiple accessory pathways in Epstein anomaly and family history of sudden death and WPW syndrome are those patients who can have sudden death due to WPW syndrome. Look at this atrial fibrillation. and it is a white QRS complex irregular tachycardia. Look at the rate. You can see what is, it's called SPERI, shortest pre-excited RR interval. Shortest pre-excited RR interval. Look at this RR interval here, shortest interval, almost 4 squares. That means it is, the heart rate is less than 200. One big square is 200 milliseconds. Your RR interval is less than 200 milliseconds. That means your accessory pathway refractive period is so short, it is able to conduct so much of more than 300 impulses to the ventricles. So this may degenerate at any time into ventricular fibrillation. So this patient should undergo radiofrequency ablation at the earliest. So what are the pathways which can have a less benign force? Whenever you have a long refractive period of the accessory pathway, which can be easily demonstrated when you do a treadmill test. As you increase the heart rate, if your accessory pathway is not getting conducted, that means it has got a long refractive period, which may have a benign force, especially when it disappears during exercise. It may have a benign force. Then give you some takeaways regarding this WPW syndrome. So many of you have been asked how to recognize the location of pathway when the patient is in cynicism. There are a lot of complex algorithms, but I just followed this for a very, very long time, even from Braunwald, which gives us a very, very simple method of locating the major pathways. For that, you have to look at V1. So in V1, you have to see whether your delta wave is positive or negative. Whenever your delta wave is positive in V1, the accessory pathway is on the left side. Whenever your delta wave is negative in V1, your accessory pathway is on the right side. So this is one. First is the delta wave is positive or negative in V1. Having seen that, next you have to concentrate on inferior leads. Come to the limb leads. So either with the left-sided pathway or the right-sided pathway, if your inferior leads are showing negative delta wave, or I can say your inferior leads are mimicking old inferior wall myocardial infarction. Many times this is mistaken for inferior wall myocardial infarction. Having assessed right side or left side, look at the inferior leads. If the inferior leads are going to mimic inferior wall myocardial infarction, because of the negative delta wave there, you are dealing with posteroseptal pathway. You are dealing with the posteroseptal pathway. This is the most commonest type. But if you have the right-sided pathway, instead of negative delta wave in inferior leads, you have a positive delta wave and upright QRS complex in inferior leads, resulting in inferior axis, the opposite. You are dealing with right-sided anteroseptal pathway. In contrast to that, in a right-sided pathway, your AVL is having the tallest QRS, not the inferior leads. AVL is showing the tallest QRS, resulting in left axis. Then it means a right free wall accessory pathway. Whereas in left side, apart from posteroseptal pathway, if your V5, V6 or L1 is going to show a negative delta wave, it means it's a left lateral pathway. So it is enough if you are able to understand and diagnose these 5 pathways from your basic sinus ECG. Let us attempt what pathway we are dealing with in this ECG. So first I look at V1, and V1 my delta wave is negative. So because my V1 delta wave is negative, I know it is right-sided accessory pathway. Then I look at my inferior leads. L2, L3, AVF. My delta wave is negative and it is mimicking inferior wall myocardial infarction. So whenever my inferior leads are mimicking inferior wall myocardial infarction, it can be a posteroseptal pathway. It can be a right-sided posteroseptal pathway if the delta wave is negative in V1. It is a left-sided posteroseptal pathway if my delta wave is positive in V1. So this is how you can actually locate the pathways through this very simple algorithm of right side versus the left side. Then look at the inferior leads. On the right side, inferior leads are negative, posteroseptal. Inferior leads are positive, anteroseptal. When AVL is positive, right free wall. On the left side, inferior leads are negative, left posteroseptal. If L1, AVL, V5, V6 is showing negative delta, left lateral pathway. So this is how we can locate the pathway, and this is a right posteroseptal pathway. So sometimes what happens is, sometimes you may not have Although you have a pre-excitation pathway or accessory pathway, it may not manifest in your electrocardiogram. That's why we call them as concealed pathway or intermittent WPW syndrome, because of the long refractive period of the accessory pathway. Look at here, because the long refractive period of the accessory pathway, before the accessory pathway front is coming to the ventricle, the normal ventricular conduction through the pathway is coming here and blocking this. So in this patient, you may not have the classical short PR and the delta wave, although this accessory pathway is existing. Whereas this accessory pathway is conducting quickly, as you can see, the shorter refractive accessory pathway, you will have the classical short PR and delta wave. So the normal ECG does not rule out pre-excitation. Then how will you approach when you have a WPW pattern in a routine ECG? Look at the symptoms, carefully go through the symptoms and also the family history. When any of the symptoms are present, families are sudden death is present, the patient will go for AP study and RF ablation. When none of these things are there, if the patient is a driver or a pilot or on whom many of the lives are dependent on, and then you have to, although these patients are asymptomatic, this patient should go for radio frequency ablation AP study. When the patient is planning for a severe physical activity or an athlete, then also they must go for EP study and RF ablation. When you have multiple pathways, and the most dangerous pathway is right anteroseptal pathway. How to diagnose a right anteroseptal pathway? I have a negative delta wave in V1. My inferior leads are positive, so that is a right anteroseptal pathway. That is one of the pathways which can have a very short refractive period. Then if none of these things are present, and if you want to risk stratify him, the best thing is to do a treadmill test to see whether on increasing the heart rate immediately my delta wave is disappearing, short PR travel is disappearing. Then you know I have a long refractive period of the accessory pathway. I followed the patient. Whereas the pre-excitation continue to happen during the fast heart rate, or pre-excitation is increasing or appearing during the fast heart rate, I understand I have a shorter refractive period of accessory pathway. Then I must do the AP study and RF ablation. To sum up my talk, the lot of pre-excitation pathways are there. The Kent bundle is connecting atrium to the ventricle, short PR and delta wave. James bundle is connecting atrium to the disc bundle, so short PR, normal QRS. Your mechanism is conducting nodovesicular or vesiculoventricular, normal PR with the delta wave. The commonest accessory pathway is the Kent bundle, which can be happening on the right side, or it can be happening on the left side. If it is happening on the left side, you will have a negative, you will have a positive delta wave in B1. If the delta wave is negative in B1, it is a right-sided accessory pathway. So in this way, you not only diagnose. How will you diagnose WPW syndrome? The activation fronts are going to come through the normal pathway and through the accessory pathway. So because the accessory pathways are coming quick to the ventricles, short PR, subsequently they are going to conduct it slowly. It will have the initial delay, the QRS complex of delta wave. So once you recognize this WPW pattern, then you look at the delta wave in V1 to say whether it is a right-sided pathway or the left-sided pathway. What is the mechanism of tachycardia here? It can be orthodromic when your antegrade conduction is to the normal pathway and retrograde conduction is to the accessory pathway. This results in narrow QRS complex regular tachycardia. The differential diagnosis is AV and RT, and carefully look at the retrograde P wave in the ST segment to diagnose AV RT. Whereas the most dangerous antidromic tachycardias are the ones which are going to conduct antegradely through the accessory pathway and retrogradely to the normal conduction system. Because of the lack of protection of the blocking effect of the AV node in the accessory bundle, this will result in either very fast white QRS complex regular tachycardia or a very fast white QRS complex regular tachycardia. Most dangerous being atrial fibrillation with the WPW syndrome, which is a very, very important factor which produces sudden death. So I think with this I conclude my session by paying tribute to these three gentlemen who in 1930s, without any sophisticated gadgets or technical advances, are able to describe all these features in 1930s. They are Louis Wolff, Sir John Parkinson, Louis Wolff, Sir John Parkinson, and the very famous Paul W. White. So you must pay tribute to these three gentlemen who gave us this wonderful insight into many of the additional pathways we may have in our hearts and their consequences, complications, and their understanding and their management. Thank you for your patience.
Thank you, Dr.